complete his super specialization in day and neurology from prestigious PGIMER Chandigarh. Dr. Razdan brings in rich clinical experience of over 35 years in this field of neurology, with special focus on remote areas of Doda, Poonch and Katwa in the state of Jammu and Kashmir. Dr. Razdan has done epidemiological work on neurological disorders in South Kashmir. He, along with his team, has published work on largest focus of deaf mutism in Doda district as well as on the disability in children in border areas of RS4R. He has worked in clinical and faculty positions in various prestigious institutions like SMHS Hospital, Kashmir, Shere Kashmir Institute of Medical Sciences, Srinagar, and ASCOMS Jammu. It's my pleasure to introduce Dr. Razdan, who is going to talk to us on Vertigo. Before I hand up the session to Sir, I would like to make an announcement that at the end of the session, we will have a question-answer round, and your audience and active participation is very important throughout the session. Over to you, Sir.
Thank you, Dr. Jayashri. It's nice to see you again. Thanks for the kind introduction. It looked so good to hear it from you. Today we are talking about general aspects of vertigo. What is vertigo? What are its types? How to make a diagnosis and how to manage patients who present with vertigo. Can I have the first slide, Dr. Jayashri?
Sure, sir. I'm just sharing my screen.
Managing vertigo in routine practice. The next slide. Okay, I can start the introduction like this. What is vertigo? The definition of vertigo is sense of sippening a person gets, meaning thereby there is a rotatory feeling of environment around the person. Some people say this is objective vertigo. There's another term which is known as subjective vertigo, where a person feels that his head is rotating inside him. That is not a true vertigo. The true vertigo is sippening of environment around you. Can I have the next slide, Jayashri? There are many people who mistake vertigo with other symptoms a person gets in the head. Like some people say giddiness or vertigo, which they actually have is a heavy head, which is not a vertigo. Some people have lightheadedness, again, which is not a vertigo. Some people sway on walking, they feel this is also vertigo. This is not a vertigo. Vertigo, and this is so important to get from the history. Otherwise, one is going to make a mistake about it. And basically, vertigo is produced by abnormality of sensation by the vestibular system, which consists of end organs in air, which are known as semicircular canals and ventricle. The nerves connecting it to the brainstem, that is the vestibular nerve, the nuclei in medulla and pons, and then their tracts going up through the brainstem in the cerebral cortex. And in fact, you can get sensations of vertigo even in disorders of brain. We can come to that. Jayashri, can we have the slide? Next one.
Connectivity is lost.
We can wait.
Dr. Jayashri, please help.
Sir, I'm changing the slide from my end. I don't know why it is not moving. I'll just share my screen again.
Please do it again. Please do. Oh yes, it's
Is it?
coming. Yeah, it's coming. It's
Okay.
coming. Right. Now, I talked about this. How to differentiate many mimics of vertigo. We got it. Got it. Can we go back? Can we go back, ma'am? Yeah. Back. No, there. Keep it there. Now, uh, as I told you, the vertigo sensation of vertigo is produced by vestibular system, which has peripheral in the ears, then the nerve, then areas of lower brainstem and central connection. Now, naturally, so many disorders can affect this system, and this can be acute, this can be subacute, this can be chronic, this can be recurrent and paroxysmal, and its duration can also vary. Depending on all combinations, we can make a diagnosis whether it is the peripheral system or is the central system, and what is the cause of each of them. The next slide, ma'am. Okay, this is a slide which shows whether the vestibular system of the periphery is involved or the center. This is very important from diagnosis, because whether patient comes with acute, subacute or chronic, we have to know where is the site of lesion, and this is a basic, very easy way of knowing where is the lesion, because there are differences between a vertigo which comes up from the peripheral organs and the central which is in the brain stem. The differences are very there can be an overlap between the two. For example, patient has tinnitus and hearing loss. This would be more common with peripheral vertigos, whether it is nerve involvement or the end organ. The type of nystagmus in the two is also different. Neighborhood signs in central vertigo, there will be other cranial nerve involvement, there will be headache, vomiting, there will be long tract signs. In fact, I now come to the first one. In a peripheral, the symptoms are mostly restricted to vertigo, tinnitus and deafness. In central, there are lot of neighborhood signs, and deafness and tinnitus is very, very rare. And duration again is an overlap. You can have less time with peripheral or more time, but it could be variable. I think the fundamental is in peripheral the symptoms are severe without much neighborhood signs. In central, the symptoms may be mild, moderate or severe, but neighborhood signs are more important. Can I have the next slide, ma'am? Okay. Now, this is a very interesting thing about vertigo, that it is affected by position of the head. Suppose you change your head position, the vertigo could change. In fact, there are a couple of vertigos which only come with change of position. This is known as positional vertigo, which is an entity by itself, as this slide shows. Benign paroxysmal positional vertigo. Some other vertigos may be also position related, but this is classical for BPPV. Rotational vertigo can happen in both conditions, central as well as peripheral, and unsteadiness or swaying is associated with all types of vertigos, and this is more common if you have central involvement or bilateral vestibular involvement. Being dizzy can happen in sulco. We'll come to that later on. Can I have the slide, Dr. Shaishri? I talked about it, that change of head position is classical for benign paroxysmal positional vertigo, and there is a type of vertigo which is associated with migraine, which happens with headaches, or it can be without headache also, which is known as vestibular migraine, and it has same triggers as you have for migraine, like during periods, during sleep deprivation you can get it, and one has to be, and again it's always diagnosed by proper history, which is paroxysmal nausea, and usually patients have associated migrainous headaches also. The other panic, anxiety spells, etc., are non-vertigo disorders. While sometimes patients mistake those things with giddiness, and in a lot of languages there is an overlap between vertigo and giddiness. For example, in Hindi and Urdu we call chakkar. Chakkar is synonymous for so many things, as I talked in the first slide also. So one has to be very careful to isolate vertigo from things which look like giddiness to the patient. One has to be very, very, it requires a lot of art, patience and active listening to differentiate true vertigo from other conditions. Can I have another slide, ma'am? Okay, this slide shows that by knowing the duration of vertigo, one can make a reasonable etiology about the vertigo, which is very important. Because unless you know the etiology of vertigo, you cannot give a proper treatment. If it remains for few seconds only, it is usually due to peripheral lesions like Meniere's disease. Actually not seconds to minutes, and even hours it can be in Meniere's and vestibular neuropathy. But in benign paroxysmal BPPV or perilymphatic, it remains for seconds to minutes, and transient ischemic episode, it remains for minutes, and perilymphatic fissure again for minutes to hours. Longer duration can happen in Meniere's, migraines, traumas, and if it happens for days, it is usually due to structural lesions in the vestibular nerve, or strokes, or demyelinating disorders. Psychogenic is variable. We'll talk about it later. Can I have the next slide, ma'am? That's very important. We talked about it. It's very important to know the cause of vertigo. This is because some vertigos need immediate attention. For example, patient starts, suppose you get a 55-year-old man or a woman who is diabetic, hypertensive and obese, and suddenly gets a vertigo. You should be very careful to rule out a vertebropatellar stroke, and in first 24 hours, in first hour, when you see the patient, immediately your clinical acumen is the most important thing. No investigation will confirm this way or that way, and that's very important. To diagnose acute vertigo, you got to rely on your clinical acumen. And this also is important, as I rightly told, it will determine what drugs to give, what therapies to give otherwise. And this is very important to know the cause of vertigo. I always tell my staff, my students, please make a positive diagnosis of vertigo. Just don't listen to vertigo and give a drug like that. The next slide, ma'am. Now, there are a lot of drugs we use in the management of vertigos, and they can be classified into mostly three groups. Like they act on vestibular system. The most of them are vestibular suppressants like antimuscarinic drug hyoscine, and more important is antiemetic cyclizine. This is a very old drug, and the generic, the name of it was Diligan. We used to use it a lot, and it's still available. Metclopramide, prochlorperazine is the usual acuvate or Stametil, which is available all over the country, abroad also. Promethazine, and some calcium channel blockers, cinnarizine, which is widely used, can also be there, and GABA agonists. The most important group of vestibular suppressant, though it is a stimulant, is a histamine which is known as beta histine. dihydrochloride. This is very widely used in the management of various types of vertigos, and it is the bedrock treatment in Meniere's disease and even in vestibular migraines. It is very safe and dosage window is huge, and high doses have also been seen to be very safe for beta histine. And I relish using this drug in especially Meniere's disease, where it has to be continued for years. Some other nootropic drugs can also be used, like ginkgo derivatives, pentoxifylline, but they are not directly. They help in vertigos, but they don't. They are not ideal drugs for acute vertigos. Can I have other slide, ma'am? I talked about it. There are other parts of are MAO inhibitors, and they are again histamine antagonists, and they decrease the level of histamine in brainstem. This is the mechanism of action, and then they produce temporary symptomatic relief from nausea, vomiting, and they have to be used for shorter time. Duration of use is lesser in these vestibular suppressants. But vestibular stimulants are H1 agonists, and they increase the level of histamine in vestibular nuclei and help in achieving accelerated vestibular compensation. That's why they are known as stimulants. They redo the vestibular systems, and they increase vasodilatation of vessels in inner ear and brainstem through their activity on H3 receptors, and better vestibular health is there. And they can be given for a long time, and they reduce severity, frequency, and recurrence of vertigo and help vestibular compensation, which is not done by vestibular suppressors. Next slide. Dr. Jayashree, can you continue beyond that?
Sure, sir.
Okay,
Sure.
okay, ma'am. Thank you so much.
Thank you so much,
I'll be
sir.
listening to you.
Thank you.
Thank you so much.